All right. So we're about 3 past. So I just want to open this up and first of all, welcome everybody to what we hope will be the first of an annual Big Ten Augmented Intelligence Bowl. It's being sponsored today by our Institute for Augmented Intelligence in Medicine, which we just launched this past year at the Feinberg School of Medicine at Northwestern. And we're really excited to get this started. I'm going to peel back the curtain a little bit and let you see that this is all being run out of a little war room, a fully vaccinated war room. Here I have to say, there's Nan, there's Meg. I just want you to see what's going on back here. And we're going to keep this kind of loose and hopefully make this fun for everybody today. So I don't know if you want to go next slide, Nan. We fully expect there'll be hiccups, but like I said, this should be interesting. So today, you should expect is I'm going to take just a couple minutes at the start to introduce the event, talk a little about the Institute. Then Rupert Evans, Professor Evans, is going to give us a keynote that really underscores the focus this year, which is again on health disparities. And then we're going to go right into the main event, which is going to be the team presentations. We've got 8 Big Ten schools. Full disclosure, I have an affiliation with 4 of them, 4 out of the 8 today, but that is not going to bias any of the judges whatsoever. I can assure you of that. So, but we're really going to, I think, look forward to seeing what great ideas people bring forward today for this event. So next slide. Oh, by the way, sort of at the end, we'll take a little bit of time. So right around 4:10 or so, we'll go ahead and have the judges have some time to think and talk through any decisions that have to be made, and then we'll be able to announce the final teams shortly thereafter. So just a couple of minutes, I want to mention a little bit about the Institute. So as I mentioned, the Institute for Augmented Intelligence is based here at the Northwestern Feinberg School of Medicine. I'm a faculty or professor here in the School of Medicine, in the Department of Medicine, and my background has been primarily in the space of building electronic networks and data sharing networks and doing things like record linkage. And so at the Institute, our mission is really focused on bridging computational methods with human expertise to advance medical science, improve human health. In reality, what we're really focused on in these first year of our Institute is really getting the data right. And it's getting sort of ways to responsibly source it, bring that data together, understand some of the ethical implications of using these data for things like artificial intelligence, and then building communities that then work together to make, again, responsible use of these data using the latest, for example, artificial intelligence, machine learning, or advanced data analytics methods. And so this event today is very much in line with our goal, which is to build this community. We've recognized that for many years, I've been at the Big Ten. I grew up here in Chicago. I've always thought it's unusual that you've got these amazing medical schools, these amazing computer science departments and engineering schools. And yet, if you look at where the field has been going, a large bulk of the content in the literature around artificial intelligence, for example, is coming out of just a handful of institutions or even a handful of states. And so an article just recently published suggested that only 3 states accounts for the vast majority of the literature out there. And so, that just didn't seem right. And so sometime in, I think, late last year, the team of us got together and we sort of were thinking, well, what are things that we can do that would sort of raise the profile? And so this idea of having an event like a bowl came up. And so our small agile team moved forward and we started putting this event together. And then that brings us to today. So next slide. So the Institute is set up like many institutes in that we have a number of different centers within the Institute. We actually have 5 sort of primary centers, and then we have a cross-listed center, that first one, bioethics, medical humanities. And this is cross-listed because it's so essential to much of what we do in medicine today. So bioethics and medical humanities, we see as sort of a foundational, it's a cornerstone for advancing analytics method. And so we think that you shouldn't move any project forward unless you have made those initial set of considerations. You've really discussed them, thought them through, brought the right stakeholders to the table. And so that's really the real sort of like cornerstone atop which every other sort of application is built. Having said that, we then have 5 focus areas. We've got one focused on medical education, which is so important. We all recognize there's a dearth of talent in this field. We need to build a bigger pipeline of people coming into the field. And so that's what that is focused on. Deep phenotyping precision therapeutics led by Dr. Sanjeev Shah. A lot of it's right now focused on cardiology because, you know, Sanjeev's a cardiologist. And as I see today, there's also a lot of cardiology that's represented today. So we're excited to see sort of what great ideas are brought forth there. Computational imaging and signal analytics, that's an important area that Dr. Lee Cooper's leading. Advanced molecular analysis, Feng Yu's leading a whole section that's focused on how do you bring some of the latest diagnostic technologies to bear, especially in the area of genomics and other sort of cellular diagnostics. And then biomedical informatics and data science. And that's actually where I train, and some of the people who are involved today did as well. And informatics is sort of the intersection of data and health. And we think that augmented intelligence is a natural sort of progression of the field. And so we're really excited to embrace it fully through events like we have today. So next slide. So I want to take some time just to really thank, a lot of this competition is really possible. And we didn't want to move forward with this until we knew that we could make this you know, a really impactful event. And that's really through the help of our sponsors. Just a few words I just want to mention. So Vizient has really gone out of their way and been really very helpful. And we recognize them as the nation's largest healthcare performance improvement company. Dr. Shannon Sims today will be representing them. And he's actually somebody I've known for many, many years, a dear friend and colleague. HCSC, you know, I'm going to read the tagline, but it says, to do everything in our power to stand with our members in sickness and in health. And when I read that out loud, I thought to myself, this is actually a good way to pick a partner. I think it's part of the marital vows. So clearly something that is, I think, really a valuable partner for us as well. Expert AI, they actually provide a natural language API that allows you to add language intelligence to any application. And so we're excited that they also have chosen to be a sponsor. Anthem improves the health of humanity. That's the mission, and we hope that through efforts like this, that's going to advance some novel applications. Nokia, we create technology to help the world act together. And then IPM.ai, and IPM is an interesting company. I've had a good chance, fortune to work with them on other research projects, and they're focused on improving patient outcomes in rare and specialty conditions through the use of real world data and machine learning. So again, a special thanks to all our sponsors today who are not only providing, in some cases, financial support, but also providing in-kind support in the form of people, which I think is actually at the end of the day, the most important contribution you can make. So next slide. So I'm really excited today to introduce our, oh, I'm sorry, one second, we got a little bit of feedback. Our keynote address, which will be given by Professor Evans. And now I was debating before this how we should introduce Professor Evans, because he has so many titles. I didn't want to get it wrong. He could be introduced as professor or doctor or major, you name it. But he's really got a tremendous sort of background. He's really, I don't think I'll do it justice, but currently he's Professor Emeritus of the Master of Health Administration program at Governor State. He previously has been involved in leadership roles within one of the federally qualified health centers within Chicago. He's served as a major in the Air Force. The list goes on, but rather than sort of belabor the point, I'd just like to maybe hand over the time to Professor Evans to go ahead and introduce us and kick us off on the importance of health disparities in this current challenging day and age. So Professor Evans.
Good afternoon, everybody. And let me see, I see that this, I want to share my screen so I can actually control my slides. Okay. Okay. Well, you know, as was said, you know, I've done a lot of things career-wise, and just to kind of let you know really a little bit on the human side, who I am and where I come from. I'm a native of Chicago. I was born and raised on the South Side. I went to high school on the South Side of Chicago, and I was born in Cook County Hospital, the old Cook County Hospital, which during when I was born was probably one of the few places that Black folks could be born in Chicago. So, you know, that was a little bit of notoriety between county and Providence. You know, that was probably where your African American population came from. If you ask anybody, where were you born? And that's basically back in the early 50s. And so it was also mentioned that I was in the Air Force, and so I was in the Medical Service Corps. So that's the Corps of Professional Healthcare Administrators for the Air Force. And in that role, I actually worked in probably every size healthcare facility that is out there. And so I've had a lot of jobs in the industry, both in direct support of patient delivery. I've worked in personnel administrative services. I've worked in resource management, which is the finance side. I've worked in health informatics. Matter of fact, I was the project officer for the Air Force's largest integrated enterprise healthcare system that was developed for healthcare facilities in the Department of Defense worldwide. It was called the Composite Healthcare System. And this was back in the 80s. And that was like I said, an enterprise-wide healthcare informatics system that integrated all of the facilities in the Department of Defense, the Army, Navy, Air Force, and we had some connection with the Veterans Administration, sharing information data across those different platforms so that we, no matter where in the world we happen to be stationed, we always had access to our medical information. So that's something that we aspire in the civilian sector to get to, but there are a variety of reasons that many of you know about for that not happening, which causes a lot of issues for delivering a coordinated healthcare platform for people, because oftentimes when someone goes to a different healthcare system for care, much of the testing, most of the information has to be repeated because they can't share that information across their different information systems. So, you know, that's something that we all need to think about improving as we go forward. So a friend of mine, Dr. Bill Guillory, he said that the law of natural selection applies to organizations in today's constantly changing business environment. In other words, those that learn to continuously adapt, survive. And a lot of what you're up to today is a part of that adapting and innovating and coming up with new solutions as they apply to solving some of the things that we want to get at as far as providing equity and eliminating disparities in the delivery of health to our various populations. And so today I'm just going to talk a little bit about these three things. You know, I'm going to talk about diversity principles, transforming organization culture a little bit, and for the purpose of improving health equity and eliminating health disparities. And then I want to get into your bailiwick a little bit by trying to understand how technology can be used in addressing health disparities, improving health equity. And then finally, talk a little bit about the influencing sources, such as the causes and effects of those things that cause health disparities in our healthcare system. So I'm gonna take you on a little bit of a world journey. And I want you to think about this. You know, valuing diversity, what would the world look like if we can condense it down to a population or a village of 100 people with all the existing human ratios remaining the same? What would it look like? Well, there would be 57 Asians, 21 Europeans, 14 from the Western Hemisphere, North and South, 8 Africans. 52 would be female and 48 would be male. 70 would be non-white and 30 would be white. 70 would be non-Christian and 30 would be Christian. And here's one that just kind of makes your hair crawl a little bit. 59% of the entire world's wealth would be in the hands of only 6 people, and all 6 of those would be citizens of the United States. 70 would be unable to read, 80 would live in substandard housing, 50 would suffer from malnutrition, one would be near death, one would be near birth, and only one would have a college education, and only one would own a computer. So when you consider the world from such a compressed perspective, the need for both tolerance and understanding become glaringly apparent as we start looking at the ills of our world. And just some of these data points just show you that we live in a very different world, and the things that we do today really don't address a lot of the things that we're going to have to deal with in the future. And so, we use the term diversity in a lot of ways. It means a lot of different things to a lot of different people. And, if I were to go around and ask everybody what their definition of diversity is, I'd get probably, I think there are about 100 people in this audience. I'd probably get about 100 different answers. But I like this one. And it was a definition that was written in a book by Dr. Roosevelt Thomas, who was a guru in the corporate diversity. And he said that diversity is a total collective mixture made up of main ones and others, and is not a function of race or gender or any other us versus them dyad, but a complex, ever-changing blend of attitudes, behaviors, and talents. So, when you think about that, we talk about in our very diverse world and our diverse communities that we serve throughout the United States, we got to figure out ways to provide optimal health care with equity among all the people that we take care of. So Healthy People 2020 defines health equity as attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally, with the focus of ongoing societal efforts addressing avoidable inequities, historical contemporary injustices, and the elimination of health and healthcare disparities. So you can see when we start talking about diversity, it leads into how do we do this? How do we take care of people and do it in an equitable way? And equity and disparities can't exist without one another. Although the term disparities is often interpreted to mean racial or ethnic disparity, many dimensions of diversity exist in the United States, particularly in health. And the health outcome is seen as a greater or lesser extent between populations where, if there's some differences in how we're treating people based on who they are or what group they're in, there's going to exist a disparity, either a disparity in the way that we're treating people or a disparity in the outcomes. And so this becomes very, very important as we deliver our work. And many of you are care deliverers, and you are where the rubber hits the road. And so, you have to think about, okay, am I doing everything possible to make sure that I don't create disparities in the way that I'm treating people, and I'm treating people with equity among all the folks that I'm taking care of. So race, ethnicity, sexual identity, age, disability, economic status, geographic location, all contribute to an individual's ability to achieve good health or not, depending on who's taking care of them and what they're doing. And then it's important to recognize the impact of societal determinants on health outcomes, specifically the populations that we take care of. And Healthy People strives to improve the health of all groups. And so that is a noble goal. And I think that all of us try to work toward that goal as we move toward taking care of our populations. So health equity. We want to better understand the context of disparities. And it's important to understand more about our US population in order to get at what does this really entail. So I'm going to talk a little bit about some demographics. In 2020, the US population was estimated at 335 million people. That's based on this current census that just happened. Also in 2020, approximately 24% or more than 81 million people identified themselves as belonging to a racial or ethnic minority population. In 2020, also 51% or 168 million people were women. So, you know, we're thinking, you're thinking about, okay, we got a large population that's different than the main population. We are seeing women outnumber men in society. And if you look into all the different components of our society, you can see firsthand just by looking around that we see more women in the workforce, we see more women in education, we see a change, and which means that that's not a bad thing. It just means that we have to be able to understand it and tool ourselves in a way that we can serve those populations in equity, with equity, and in a appropriate way. In 2019, 12% or 36 million people not living in nursing homes or other residential care facilities had a disability. So that means that they had a disability, but they weren't in a care environment, which means that they were being cared for at home or not being cared for at home. In 2019, estimated 70.5 million people lived in rural areas, 23% of the population, while roughly 233 million people lived in urban areas, or 77%. And so what does that mean? That many of our population are hard to reach. They're in areas where they don't have a routine source of care, or their care provider may be hundreds of miles away. So are they going to be able to, are we going to be able to equitably serve those populations when we have these huge distances and we have people spread out so far and they're not in population centers like many of our Americans that live in urban areas? And it's estimated that 4% of the population ages 18 to 44 identify themselves as lesbian, gay, bisexual, or transgender. And so, you know, that's another group of individuals that we have to pay special attention to as we're providing care to make sure that we're serving them. So it's a national imperative. You know, we're an increasingly diverse country. You know, there's a lot of conversation that's going on right now, and we see it every day. You turn on the news and you look at the talking heads, you know that there are issues that exist because of the diversity of our country, because people are different and people don't understand the differences, or sometimes don't want to understand the differences. We have, a lot of people don't want to admit it, but there are systemic racisms that exist in our country. We go through them every day, and they're not limited to any particular group. It just exists all over the place. It was the Black and Latinx community, and then it was the Chinese community, and then there were subgroups within the major Anglo community. So all of this is important to understand, and if we don't understand it, if we can't do anything about it. Because think about it, back in 1900, 1 in every 8 Americans was non-white. 1 in 8. Today, it's 1 in 4. By 2050, it'll be 1 in 3. So we are a changing country, and there's not going to be a majority. We won't even be able to talk about it in those terms in the future. Because if you look out there, the top 100 cities in the United States don't have a true majority population. So many of our large metropolitan areas are really majority cities. That means that they have a little bit of everything in them to make them, and that's not a bad thing. That's a good thing, because think about the beauty of the diversity that's being brought into our cities. Think about the multitude of cultures that people can embrace and understand that make it a more pleasurable place to live. I don't think I want to live in a homogeneous society where everybody's the same. What's the fun or what's the beauty in that? So, but do we do things the same way we've always done them? No, we can't. We have to change. We have to adapt, and we have to do things better because there's going to be a larger demand every year for services that serve the minority populations of our country. And I know that if you went to medical school, you probably were required to read the IOM report back in March of 2002, where they were talking about the disparities between racial and ethnic minorities, and which said very clearly, and it made a lot of healthcare providers uncomfortable, but basically what it said that minorities were receiving lower quality healthcare than whites, even though even if insurance status, income, and age were the same, the severity conditions were comparable. And it also said that, well, the bottom line, it said that people were being treated poorly in our healthcare system, not because we don't have the ability or the technology or the skills to take care of everyone in an equitable way. It was because they were being discriminated because of who they were. And that was a big black eye for our medical society. And so, that's something that we have been working toward overcoming. And I know that a lot of the work has been done, but, we still have a long way to go. And, this talks about the why, and I wanted to share this with you because there are two large factors that contribute to racial and ethnic disparities in healthcare. They're the patient-related factors and they're the health system factors. Now, when you start looking at the patient-related factors, you see those things that that we all can recognize: social economic differences, patients' income and education, the health education differences, patients' knowledge of the healthcare symptoms, conditions, and possible treatments that they can get. The behavioral differences, patients' willingness to accept and seek care and adhere to treatment protocols and trust the healthcare community to do what's best for them. And believe it or not, that's one of the ones that's so hard for the healthcare community to deal with, because changing behavior is extremely difficult. Many people know what causes cancer, what causes diabetes, many people know that smoking's bad for them. Many people know that being obese can be a comorbidity to a lot of different conditions that will adversely affect their health. Yet they still do the behaviors that will cause those kind of things. So change of behavior is one of those things that we have to continually work on. On the health system factors, these are things that we can actually do something about. Cultural competence differences. We can learn to be culturally competent, and competence means doing something. Competence doesn't mean, it's not stagnant. It's not okay, yeah, I recognize that people are different, and so I'm culturally competent. No, that's not the answer. Cultural competence is you actively doing something to change yourself so that you can understand and be able to act in a competent way about dealing with patients and the people that you're serving. Language differences. We can address that. Discrimination, in the workplace and among those individuals that are receiving care. Yes, we can address those and change that. Workforce diversity. We can hire different people to come into our organizations and more represent the communities that they serve. Payment differences. A constant debate. Healthcare for all. Are we ever going to get there? Are we going to continue to have a system that's based on the economics? And are we going to continue to have money as a driving factor in how we are able to deliver care in our country and how much we pay for drugs and those kinds of things? coverage differences, insurance, that talks about the payment differences, and then data deficiencies, and many of those type of things are the things that you're working on right now. Because if you can collect and understand the data, you can come up with interventions in delivering the care. And but both sides of this equation result, when not done properly, result in the racial and ethnic disparities in healthcare. And that's the challenge, is how do we work on both sides of the equation equally to provide equity in healthcare so that we can eliminate disparities. And so, organizations have to look at disparities, and they would not exist if provider organizations truly reflected the communities they serve. Okay, that sounds nice, doesn't it? I used to be the president and CEO of the Institute for Diversity in Health Management. I traveled all over the country talking to hospital leadership, CEOs, CMOs, about understanding the business case for diversity in their organizations. And what I found, that a lot of people aren't bad people. They're not doing anything that's intentionally trying to hurt the communities they serve. But many of the organizations that are out there don't represent the communities they serve. I'll use Chicagoland as a good example. I mean, if you look at the major healthcare provider organizations in Chicagoland, and you look in the Tiptoe Alley or at the top of the organization in the C-suite, what do you see? I'll let you answer that question. You don't see me, or you rarely see me, if you know what I mean. Culturally and linguistically competent organizations consist of the following: diversity in leadership and providers, defining culture broadly, not in a capsule, and value patient, client, and staff differences. And valuing them will help you as you start to move in that direction. And then cultural and linguistically competent organizations facilitate learning, involve community, and define need, institutionalize culturally appropriate practices, and leverage diversity. So getting to what you all are all about on this journey toward looking at AI and its way that it could start to help eliminate disparities and create equity, technology can be leveraged to help us realize this vision several ways. Many of you are working on telehealth, expanding access to care by not being able to get to other communities. And we already talked earlier about people living in rural areas. Maybe telehealth is an opportunity for providing services to people that can't be reached or that are so far away from care that we have to come up with innovative ways to get to them. Virtual care minimizes travel as well as time away from work at home, and which can disproportionately impact hourly workers and people that don't have sick time or can't get off from work to go for care. Technology can be leveraged to help us realize other things, video and phone visits. Since we've had COVID-19, this has taken off. I remember never thinking about having my primary care provider, doing a virtual visit with me. But now that's normal. Now you're seeing physicians having to work with their patients through telecommunication, through Zooming, through all kinds of other ways than being face-to-face. And then application circles provide education to new and expectant mothers and patients to ensure their access from the latest peer-reviewed expertise and literature. So these are innovations that are being used right now, and we're hoping that as you go through this competition, that you will come up with others that can be shared with the greater community on how we can use technology to improve equity and eliminate disparities. So with that, 2020, it's been a rough year for everybody. And so I would like to open it up to any questions that you might have.
Great. Professor Evans, thank you so much. That was a great talk. I love that section you had about the island. Like if we were all shrunk down and 100 people were, we were all represented by 100 people. That is just such a, I think, amazing to see those numbers, humbling to see those numbers. We're going to open up to questions. I do see one question coming in through the chat, and I'm not sure if we're able to unmute people.
Yes,
We are, okay. But I see Ann Lee had a question, and so let me see if we can pull this off. So now, do you want to try to unmute her?
Yeah.
And we're going to unmute you shortly. Heads up.
Okay.
Go ahead,
Okay.
Ann.
Can you hear me?
Yes.
Yes, we can hear you.
Great. Well, thank you for your talk. It's very interesting. You had mentioned that the IOM report that was done back in 2002 talked about the issues of health disparities. Since then, that's about 20 years ago. So since then, has there been any improvements after that study? And if so, can you quantify what the improvements have been?
You know, I have to say, yes, there have been improvements, and but I can't quantify them because I didn't research that part. But I know that ever since then, there's been a concerted effort by healthcare provider organizations and researchers, health researchers, everybody, to work on this whole issue. Because before that, nobody was even talking about health disparities. They weren't, they were in denial. People were saying, when they heard that, it was, oh, not me. I treat everybody fairly regardless of who they are. I don't treat anybody any differently. But now schools, medical schools have started to add to their curriculum issues around how to eliminate disparities. I know that many of the research organizations now have made it a point to look at the community participative research that's going on in many of our large cities. I know that that's going on right here in Chicagoland through Capricorn and Corey, looking at, listening to patients and trying to figure out how do they perceive they're being treated in the healthcare marketplace. And so I know that was kind of a crooked answer to your question, but there are a lot of things, a lot of activities that are going on and have started to go on since 20 years ago when the IOM report was published. So I'm optimistic that things are moving in a positive direction, but I don't have any concrete data to support that right now.
The outcomes. Okay, thank you very much.
Thank you, Ann. And I see another two questions. I see Yaroslav is the name I can read, so we're gonna maybe we can try to unmute Yaroslav for your question about food deserts, and I may also chime in on this after your response, Professor Evans. So Yaroslav, are you unmuted?
Yeah.
1 second.
Yeah. Okay.
You can unmute now, Yaroslav.
Thank you so much, sir. And thank you, Professor Evans, for your wonderful talk. Food deserts in underserved communities are often discussed, but data deserts in these communities also very likely exist. So how do we increase the amount of data that's available on underserved communities? And how do we use this to decrease data bias and artificial intelligence bias for our technology solutions?
Well, I know that some of the big providers of information like Comcast and others are actually trying to be innovative around providing underserved areas with access to the internet so that they could actually start, to address the problem of the data deficiencies that exist in many areas. And you probably already know that, when we start talking about rural areas, we have many places in the United States that don't have access to the internet. And so I think that a part of what our new president is trying to do as far as this infrastructure is to eliminate that, to try to provide broadband to almost every place that you could possibly provide it out in the world, so that people can access they can use a computer, they can access you know, telehealth and things like that. And researchers can actually go to those individuals and find out what are some of the key conditions that they should be addressing, you know, as they start to put in, find information so they can put into intervention. And, you know, and I'll give a specific example. You know, there was a group of, and I'm not going to say what school, but some researchers, PhDs, went to one of our native communities, reservation, and they came back and they said, hey, we know how we're going to be able to help this community with, you know, with, we're going to have telehealth there, and we're going to reach out to them, you know, using, you know, the technology, and everything's going to be wonderful. And what they found out was that many of the homes didn't even have electricity. So you can put as much technology as you want out there. If you don't have electricity, if you don't have running water, you're not solving the problem. And so, you know, we have to think about things in a different way, and we have to kind of, you know, start to look at those deficiencies and say, okay, how do we get to the root cause of it? And once you figure out the root cause, then you can come up with interventions. And so data, you know, I mean, we've got lots of scientists out there that are looking at data up, down, sideways. And most of the time is, you know, to write a nice paper, put it in the New England Journal of Medicine or the Harvard Review. But I think the trend toward the future has got to be community participative research, you know, where we actually get the community involved and engaged in trying to figure out what's best for them.
And I would just add, there's a really nice example, I think, down in University of Chicago, the Urban Health Initiative group has done really excellent work on engaging the community, as Professor Evans pointed out. I think Stacy Lindow had done some work where there was the MAPS core team that would go and do ground truth of what was happening within communities. And so we've seen some really interesting sort of ground up data sort of acquisition efforts. But also, as Professor Evans points out, you also need to have sort of the policy level, you know, efforts as well. You know, we had a conversation yesterday with Tammy Duckworth's office, and she sits on one of the subcommittees that's focused around things like broadband. And so that's as Professor Evans pointed out, that's also a need to be able to extend out the infrastructure as well to enable this collection. You know, because I think it's going to be sort of this multi-level effort. It's going to be ground up. It's going to be industry, you know, taking better advantage of the technology in your pocket and to capture these data points, researcher efforts, and then also, you know, those policy level interventions.
So Daniel has a question next. Daniel, I just unmuted you.
Thank you for speaking with us. I was just going to build off of Yaroslav's question. Do you think we should change how details are reported in studies? It seems like it's very binary right now, male, female. Do you think it should, for example, do you think it should be going further than that on a policy level where we sort of force researchers to report more specific variables or endpoints?
Well, I think it depends on how you define your study. It depends on what exactly you're looking at, you know, and then you can start to talk about what data points you need to justify your position, because, you know, I mean, you know, if you're looking at something that from a very pinpointed method of trying to home in on just one precise community or one precise condition, then, you know, you may not broaden it. You know, it depends on how, you know, it depends. I have to say that one is one of those depends. And I know going back to I think part of his question was on the food deserts. I know that many of you might know Dr. Terry Mason, and you know, he was county health director for a while, and he was the city Department of Chicago health director. And you know, he spent a lot of time, or has been, and still spending time looking at the whole issue of food deserts. And using food as medicine, and and getting people to change their habits around what they eat, what they put in their system. So like, you might want to kind of look up some of the work that he's been doing, as far as food as medicine, because I think that's very interesting. He's done a lot of studies on how that can improve the community where food is rare, and using community gardens and that sort of
Thank you.
Great, thank you. Yeah, and we're aware of some other noise out there in the chat, so we're working on that.
Sheila has a
Um,
question,
but-
so I'm gonna unmute her.
Yeah, so Sheila?
Hi, thank you so much for joining us today. It's really great presentation. I was wondering, Dr. Evans, if you could talk about instances of involving those kinds of communities, whether they be on the res or they be in a neighborhood, so that those communities are part of the conversation rather than researchers or engineers or clinicians kind of acting like on what they think is needed. So the community is a partner rather than a spectator.
Yeah, that's the old way is, okay, we're the researchers, we're here to help you. And then we do some research and we write some papers and you never see us again. No, right now, there's some very active groups that are looking at the community participative research that's going on here in the Abel, you have to help me with this one. What is the big consortium of Northwestern and Rush and the West Side?
West Side United. West Side
Yeah,
United.
yeah.
That's right.
Well, of course, they are working with Capricorn, which is the big health disparities research organization, and Corey on doing just what she said is, doing community-based participative research where you go into the community, you're listening to them, you're bringing them in as research partners, you're incentivizing them to be involved. And that, I believe, is paying dividends. And I know that some of the outcomes of those types of research studies are going to be very powerful, and many of them are a work in progress.
Yeah, and I think that those are great examples. Like West Side United also, there's also really exciting efforts happening through some research consortia that have formed that are partnering with West Side United, sort of extending that work into the South Side as well through networks of faith-based organizations. We have a project currently that started funded by NHLBI called Circle Chicago that's working on something similar to that. And so, I think that there's, increasing attention at the federal level towards providing funding to extend these efforts. Many of them started actually grassroots though. But what's nice to see is that there's finally some federal level support, and hopefully that'll just continue to grow. So I also see, and again, I think we're working on the other issue, but Onyi had a comment as well that I don't know if you want to, we can unmute.
Only you can unmute yourself, actually.
Okay, can you hear me?
Yes.
Oh, okay. Okay, thanks. Yeah, my comment was in response to, I think it was the individual that responded to Yaroslav's question. So sorry, I might get the sequencing wrong, but just in terms of the data and the expansion of data, I think given where we are, I mean, the pandemic really seems to have exploded the interest in data that, Abel, practically shouting about for the better part of how many years, right?
Yep.
But now it's front and center. And, this is really a great opportunity to get ahead of some of the things, the shifts and the changes that we're seeing in society, and being able to, apply a very solid research lens so that we can glean, more insights and continue to make advancements. And so with that, having said that, we look at the, specific health outcomes. As most of you may be aware, huge disparities in maternal health outcomes for Black women in Illinois and really across the nation, but I'm just calling out Illinois specifically because there's been active legislation in the past several weeks actually to help combat that. One example being the expansion of Medicaid for a year as opposed to, I think it was like maybe 6 weeks or something, a short period of time for women on Medicaid. And so that's one area of huge disparity that, we definitely need to target. And then, there are also, related to the pandemic, the blood clots associated with a very, very small percentage of individuals that have gotten a vaccine. However, they've been in female individuals who got the Johnson & Johnson vaccine. Very, very small percentage, but still significant in that it highlights the need for us to still capture, particularly in the healthcare space, data aligned to male and female, but it also speaks to the need for us to expand the data so that we're also capturing some of the, other, kind of when we go into the gender identity space, we're still capturing that data and able to do research, but we're not compromising what could potentially have, serious implications based on, clinical outcomes. And so I just wanted to call that out because it's really a call to all of our institutions to begin to really place a lot of focus, not just on getting a lot of data, but on the integrity of that data and how it's going to be used going forward. So.
Absolutely. And the governor just yesterday signed a bill to address health disparities in the state of Illinois. So I think it's reaching the highest levels of government that something needs to be done. There needs to be action more than talk.
And Oni, I just want this is something I care deeply about. Like this, what people we're increasingly recognizing is that a person's identity is not static. It's constantly in flux. It's constantly changing.
Yeah.
And the data standards have to adjust accordingly. So, we've been doing work for the past several years on trying to capture just simple demographic data, that might be used, for example, to link people across different sites. What we've seen from 2010 onwards for the past 10 years is that used to be that you could use social security numbers, that would work. That doesn't work because no one captures that anymore. Gender, that's changed. We're increasingly, especially during the pandemic, there's been a real spike in the types of demographic data we capture. So we never really cared about your employment status but now we care about it because if there's an outbreak, we need to know, do you work, for example, at a nursing home? People's sexual orientation wasn't captured before. Where you were born, country of birth, wasn't captured. All these things mean that we can't really do good disparities research or improve things until we first figure out how to effectively capture, articulate, measure that in a way that is dynamic and adjusts according to the self-expressed identity of an individual. And that means oftentimes you have to be much more engaging of individuals than the current very transactional nature of healthcare today. So when you go in and you can check in right now, the majority of the time registration clerks still look at you and they make a judgment about you in that microsecond. And that is what defines you going forward for purposes of research or for quality improvement work. Well, that probably can't stand. And so if we're going to do this well, it's a combination of policies. It's going to be retraining and education. It's going to be some technology, and it's going to take some time and effort. And so, I think that's just really super important point you bring up. And we're going to be really excited to see how some of that is addressed in the discussion.
Absolutely, 100% agree.
Yeah. So thank you for bringing that topic up. I think those were most of the questions. Let me just do a quick flip through. Okay, all right. Very good. So can't thank you enough, Professor Evans. Thank you. The insights, I love that island slide. I'm gonna have to ask you about that later. So what we had planned at this time was a break, but what we'd like people to do is come back at 1:10. And at 1:10, we're gonna introduce the judges and then outline the event sort of like flow going forward. All right. And so if you guys can go ahead and just turn your cameras off, leave it on. At 1:10, come on back, and then we'll introduce judges and then start the competition. So see you at 1:10. Thank you. All right, welcome back, everybody. So I hope for some who were on the break, if you might have seen a video featuring several of our faculty here. Dr. Yancey is just as much of a rock star as he looks like on that video. and is really somebody who I think is under his leadership. We're feeling pretty good that there's going to be some progress made in this area. So welcome back, and Nan's going to share the screen, and we're going to just do a quick introduction of our judges. And so, for purposes of the next stage, this is 8 teams. The format for today is that there will be 10 minutes for the presentation, which we'll keep time on. 10 minutes for just the judges to provide or ask questions of the teams, and then we'll keep it on track there. So about 20 minutes. And so the judges, this is not like Monday Night Football. We're not going to have anybody's profiles, but we just have one slide. So first. Yeah, thank you. So Professor Evans is going to be our lead off on one of our judges. So he's going to, we've heard his great presentation today. And so we look forward to hearing his feedback during the discussion section as well. Next one. Onye Daniel. So Onye's Senior Director of Data and Analytics Transformation and Planning at HCSC. So welcome, Onye. Great. And then we have our own Tara Lago. Tara comes to us from Bay State, but she recently joined the faculty here at the Feinberg School of Medicine. She's director of the Center for Health Services and Outcomes Research, an expert in disability research, and I can say a great colleague. I've had the great pleasure of working with her on a recent submission, and she's just not only incredibly sort of accomplished, but also just a lot of fun to work with. So, next slide. Armando, another wonderful colleague. Armando actually has been kind enough to serve as on our external advisory board for the Institute. And he's a co-founder and managing director for Tensility Venture Partners, which invests primarily in enterprise software solutions and has had quite a number of really impressive investments over the years, names that you would recognize. Next slide. Shalina Ramnarine is joining us from Janssen, where she's product director of cardiovascular payer marketing. And we look forward to hearing her insights as she brings a perspective at the intersection of industry, technology, as well as disparities of work. And so thank you, Shalina. And then Shannon Sims. Shannon is the Vice President for Data Intelligence and Interoperability at the Vizient Center for Advanced Analytics and Informatics. He's actually somebody who's got a rather, some would say that it's itinerant. I think that it's a super fascinating and innovative path in his career. He had been trained here at Northwestern, but then completing a PhD in biomedical informatics at Utah, and has worked in several leadership roles, both in academia as well as now in industry. And so we look forward to his insights and questions for our contestants today. In addition, I just want to point out a few things. So for those who are listening, pay attention. So at the end of every presentation, while the judges are asking questions of the presenters, there's going to be an opportunity to answer some opinion questions. So you can also weigh in on the presentations today. Those scores will be tallied, and they do make an impact. And so we are going to take things, and they're going to be more fun things. It's not going to be just fact-based, but take a look at the questions. Please answer them if you can. We'll tally them up, and we'll provide those scores at the end, and that will be used for potentially some side prizes, and maybe for those who go on to the final competition. The 5 teams that go on to the final competition may also be a factor in some of the judging going forward at the finals. So with that, I'm going to pass it over.